Welcome to Georgia Heart Grand Rounds. This program is brought to you by Georgia Heart Institute. Any financial relationships of the planners and speakers have been mitigated. If you have a question for the presenters, please wait until the Q&A segment. The evaluation will be shared at the end of the program. If you're watching online, you can submit your questions in the question and answer feature and we'll read it aloud. Your evaluation will also be posted into the chat. And now it is my pleasure to introduce our first speaker, Dr. Alex Adams. Dr. Adams was born and raised in a small town in western Kentucky called Murray, Kentucky. He completed his undergraduate degree at the local university and then proceeded to work as a paramedic for 2 years before he started medical school at LMU DCOM in Harrogate, Tennessee. He completed his internal medicine residency training here in Gainesville and will be graduating in our inaugural cardiology fellowship class at the end of this month. He will be working as a non-invasive cardiologist next year with interest in cardiac and structural imaging. Please join me in welcoming Dr. Adams.
Okay, so today we're going to be talking about cardiac CT, the role and assessment for left atrial appendage. So the objectives of the talk today is we're going to talk about cardiac CT acquisition assessment of the left atrial appendage, predominantly looking for the morphology and for thrombus evaluation. We're also going to talk about how CT looks for pre-left atrial appendage occlusion assessment, and after you put in a left atrial appendage occluder, how we assess it for complications. So what is the left atrial appendage? Let's start there. So left atrial appendage is a embryonic remnant from the left atrium. The physiological role is kind of debated. It has some impact in regulating pressure in the left atrium. It also has stretch receptors on it that impact blood pressure. The left atrial appendage has this narrow opening. It's a complex trabeculated interior with lots of folds and crevices. So why is the left atrial appendage even important? Well, it all comes down to this nasty rhythm we like to call atrial fibrillation. So in AFib, when this atrium don't contract effectively, the blood can become stagnant, especially in the left atrial appendage, and this increases the likelihood of the thrombus formation. So over 90% of atrial thrombi in patients with non-valvular AFib occur in the left atrial appendage. So in the problem with that, if a clot forms in the left atrial appendage, it can dislodge, travel to the brain, and cause a stroke. So the typical treatment for atrial fibrillation is we put patients on anticoagulation. Now where the left atrial appendage plays a role is, for example, if 90% of our thrombi come from there and you can't be on anticoagulation, we have this new technology now with a left atrial appendage occluder device, either with a Watchman Flex or the Amplatz occluder, where we can go in and seal off that left atrial appendage and overall decrease your risk for stroke. So just kind of talking about the procedure, nowadays it's a very benign procedure. It's an outpatient same-day procedure. We put a catheter in the femoral vein in your groin, run a catheter up to the heart, cross from the right to the left side of the heart, and we put this little occluder device, as you can tell, in the left atrial appendage and seal it off, and hopefully decreasing your risk for stroke for those patients that can't tolerate anticoagulation. So how does cardiac CT play a role in this? Well, cardiac CT, for those that may not be familiar, is a non-invasive imaging modality that uses contrast-enhanced EKG gating to assess cardiac anatomy and vasculature. The assessments for left atrial appendage assessment with cardiac CT are that it has high spatial resolution and 3D visualization, and it's a non-invasive, that's the key word, non-invasive and rapid acquisition approach. So, cardiac CT predominantly has 3 specific roles in left atrial appendage assessment that we're going to talk about. The first one is left atrial appendage thrombus assessment. Whether you're going for a pre-ablation or you need a cardioversion for your atrial fibrillation, a CCTA can identify filling defects in the left atrial appendage suggestive of a thrombus. It also can help you occluder device, help assess the morphology, the dimensions, and also after you get some kind of occluder device with a Watchman or Amplatz, it can help you evaluate the device for positioning, thrombus, or peri-device leak. So just kind of looking at cardiac CT. Cardiac CT kind of gives you those, you can kind of set it up to give your same standard views as you can as an echo. You can see on the left, on the left we have our typical 4-chamber view. You can set it up to get your typical 2-chamber view, and then you can also focus on specific structures like the left atrial appendage. So how does cardiac CT compare with TEE for left atrial appendage thrombus evaluation? Well, to note that TEE has been for a many long time been noted as the gold standard for left atrial appendage thrombus detection. But TEE has its own risks and complications, right? It can induce discomfort and complications, and it's contraindicated in patients with low platelets, dysphagia, gastric varices, or those that have contraindications to sedation. So in 2021, there was a meta-analysis that was done, reviewed 27 studies from 1977 to 2021, about 7,000 patients, and it showed that cardiac CT with delayed imaging is non-inferior to TEE for evaluation for thrombus. So how does cardiac CT match up? So when you look at it here, you have the left atrium, let me get my pointer, left atrium, your left atrial appendage, right? And these are your different views to look at it here. So in this one, you can see this is a normal scan done. There is no evidence of thrombus on our initial scan. Now here's what happens with cardiac CT is sometimes, what if we have on our initial scan, you get this area here, this hypoattenuation. It could be a thrombus, it could not be. And we notice if you do a delayed scan at 1 minute, you can see that the left atrial appendage completely opacifies. That area of thrombus that was previously there is completely resolved. Now the reason for this, and we've noticed with cardiac CT, is if you have stagnant flow in the left atrium, or the left atrial appendage, or you have low cardiac output, you can get sluggish flow and it takes time for that contrast to wash or to completely opacify that left atrial appendage, which can make it seem like you have a thrombus when you don't. So typically, the standard protocol, which we do at this hospital, and that it's done by a lot of studies, is they'll do a 1 minute study. So you'll do your initial scan at 0 minutes, and then you'll repeat a scan anywhere from 45 seconds to a minute, just to make sure to allow for contrast to completely opacify the left atrial appendage. Now, what happens if you still have a persistent left atrial appendage filling defect? So this is something that has been noticed with cardiac CT when comparing TEE, that some patients, just from sluggish flow or obesity or the anatomy of their left atrial appendage, they're still gonna have this specific defect even at 1 minute. So there's been multiple studies looking about, okay, is this truly some kind of thrombus? And when they compared it with TEE, they noticed, okay, maybe it wasn't a thrombus. So there's different studies they've been looking at. This is the one published from 2024, we'll talk about in the next slide, from Scientific Reports, that shows in patients that still had this left atrial appendage thrombus here at 1 minute. So here is your initial time at 0. Then at 1 minute, they still have this evidence of this opacification in the left atrial appendage concerning for thrombus. They either, in the top one, we flipped the patient over, did prone positioning, so here's the left atrial appendage here, or we delayed it and did it at 3 minutes, and there is no evidence of any type of hypoattenuation or evidence or concern for thrombus. So the issue with this, though, is if you look at your initial scan, at 0 minutes at the time, your radiation dose is only 4.2 millisieverts. If you had to add that extra 1 minute delay, your total effective radiation dose is 7.3. Now, if we just routinely start doing triple phase scanning on every single patient, you notice that your radiation effective dose increases. You have 10.7 millisieverts. So this study that was recently done, and we talked about in the last slide, is 138 patients recently published in Scientific Reports. They showed that the absence of a left atrial filling defect on CT, it allows for a very confident exclusion of thrombus with a sensitivity and negative predictive value of 100%, thus removing the need for their further TEE assessment. Now, I just want to kind of preface here. So if it comes to that first slide where you saw that there is no evidence of any kind of filling defect in the left atrial appendage, you can very confidently say, okay, this is definitely no evidence of thrombus. But if it comes to the fact that you have a filling defect, you can't necessarily 100% confidently say this is a thrombus without delayed imaging or considering doing a TEE to completely exclude that. In this study of 138 patients, using the delayed protocols, which there were 3 different studies a part of it, one used a dual phase and a triple phase, they were able to successfully exclude and identify when comparing this with TEE to confirm that all these patients with filling defects except for one did have left atrial appendage thrombus. So that would be the limitation in cardiac CT, not ruling it out, but if there is some concern for thrombus, verifying and confirming that that actually is a thrombus. So the other thing that's good about cardiac CT, if you're doing this for pre-ablation assessment for left atrial appendage thrombus, it also gives you a good visualization of the cardiac anatomy. And if you're going to get an ablation done, knowing where your pulmonary veins are, if there's any anomalous pulmonary veins, is very helpful. And you can even, depending on what software you use, certain programs, you can actually do this fusion imaging where you can overlay your cardiac CT images with your left atrial appendage mapping software, and it allows you to give good visualization of targets and areas that you're looking for. Other good things for cardiac CT planning, like we talked about, it allows you to exclude a left atrial appendage thrombus. It allows you to plan for your transseptal puncture. It gives you a good idea of the dimensions and the device sizing and selection. So when you're device sizing for a Watchman, you can see it's very important to do two things specifically. We're trying to find this line across, what's the actual width that we need to occlude the left atrial appendage, and that's going to be a line that you draw between the left circumflex and about 1 to 2 centimeters inside the left atrial appendage from the left upper pulmonary ridge, and then measure the depth. This is very good because it kind of gives you sizing as what's kind of idea of what size is going to adequately occlude it, and then also is a Watchman device or an implant better suited for left atrial appendage occlusion. Now when it comes to post-procedural left atrial appendage imaging, it allows you to see a lot of different things. Main things that we're looking for specifically is peri-device leak or device-related thrombus, but it also gives you imaging if a patient were to have some kind of pericardial effusion that's late, or if the device migrates. Cardiac CT gives you really good evaluation of all of that. So how does TE compare to CCTA as far as post left atrial appendage implant? So if you look at the 2023 SCI HRS Expert Consensus Statement on transcatheter left atrial appendage enclosure, which was also endorsed by the ACC and this SCCT, that at 45-day follow-up, it's actually strongly recommended over TEE to do CCTA, and it gives you what they consider a stronger recommendation for evaluation of peri-device leak, and it's equally equivocal for device-related thrombus. So let's look through in some of the complications that you can have. So this is evidence here of pericardial effusion. Now, when we do a left atrial appendage occlusion, typically you're going to have pericardial effusion post-procedure immediately. You're going to catch it on a post-procedure TEE or 40 ICE catheter during the procedure. But some patients, less than 1%, can present with this late pericardial effusion that you can detect. You can also see if the device, for some reason, were to pop out of the left atrial appendage and embolize here, as you can tell, in the descending aorta. But the two things that we care most about and that we see the most commonly is there evidence of peri-device leak. As you can see here, peri-device leak, you have Amplat's device here. Here's your left atrial appendage. You can very clearly see that there's this channel or tunnel where that there's going to be leak where contrast or blood can flow around the left atrial appendage and still form thrombus. Now there's other situations like this Amplat's and this Watchman Flex device. They look like they're completely occluding the device, but we can compare here this region of interest of blood and the left atrial appendage back here, compare it to the left atrium to determine if there's actually flow behind it. So if you completely occlude this left atrial appendage here, then this region of interest behind it should be consistent with some kind of thrombus because it's not getting blood flow and it's sealed. So there is a typo here. I'm going to say that this left atrial appendice present when the left atrial appendage is less than 100 Hounsfield units. So if this number 314 in this Watchman Flex here is less than 100, we can adequately say that this is completely occluded or sealed. Typically, you're going to see thrombus anywhere between 60 and 100. So we can confidently say if this number here is less than 100, then this is adequately sealed. Or if your left atrial appendage ratio, so the ratio of the Hounsfield units of the region of interest in the left atrium, compare it to the left atrial appendage. If this is less than 25%, then we can confidently say that there is no evidence and there's complete occlusion. Other good things about cardiac CT when we look for peri-device leak, it kind of gives you an idea of what's the mechanism for your peri-device leak. Is it an uncovered left atrial appendage lobe where we just completely did not seal it, we undersized? Is it because the device was uncovered the proximal left atrial portion of the tissue? Was the device too proximal and not seated in the left atrial appendage enough, and so we have this residual channel? Or did the device get implanted sideways, which left an area or a tunnel for flow around the device? So the question I guess we all have is, if we find these evidence of peri-device leaks on CT, what do we do about it? So I think we can say if there's complete occlusion, that we can feel confident and say there's nothing else to do. Now, if there is patency with visible peri-device leak, like in that first slide, you can obviously see a channel and measure it. Then it comes down to how important is it? So is it clinically significant or not? Now, there's no specific published literature when it comes to cardiac CT saying what is considered a large peri-device leak versus a small. But when you look at TE, they consider a large peri-device leak greater than 3 or greater than 5 millimeters, depending on the published literature. So I think we can confidently say that anything that's greater than 3 millimeters on cardiac CT most likely is a large, significant peri-device leak. You should consider either intervention or long-term anticoagulation because it's an incomplete sealed left atrial appendage. Or if it's a small peri-device leak, less than 3 millimeters, I think taking a conservative approach is also appropriate. And for those like we talked about on the previous slide, where there's no evidence of any type of peri-device leak, but the Hounsfield units or the region of interest in the left atrial appendage is over 100, which means that they're still getting flow somewhere either through the fabric or around the device that we can't see, it's probably clinically insignificant, and so a conservative approach is appropriate. So that's device leaks if we don't seal it. What if we identify thrombus or evidence of hypoattenuation on the proximal edge of the left atrial appendage occluder? So this area is concerning for a device-related thrombus. So as we noticed with cardiac CT, because our imaging is such high resolution, we started picking up these areas of hypoattenuation thickening that we weren't seeing on TEE. So let me go through those to you. And so we've come up with this grading system to determine how we would grade this hypoattenuation and thickening. Is it important or clinically significant, and how do we treat it? So you can look at, we call this grade 0. So if the hypoattenuation thickening, which is specifically seen in a Watchman flex, is isolated in the screw hub cove, so right here, then we call that grade 0 or subfabric hypoattenuation thickening and clinically insignificant. Now when it comes to grade 1 hypoattenuation, those with thickness that's less than 3 millimeters, or if it's greater than 3 millimeters, as you can see here, but it's very continuous with the left atrial appendage, then we can call that grade 1. Now grade 2, grade 3, the ones where you get concerned about, is when you have this thickness that's greater than 3 millimeters, but it's not continuous with the left atrial appendage wall. You can see the left atrial appendage wall, and then it comes in, and then there's another hypoattenuation thickening. Or if it's a very irregular surface, or you see this pedunculated area that sticks out, these are all concerning for grade 2 and grade 3 hypoattenuation thickening. So how does that compare with with TEE? So these low-grade hypoattenuation thickening, whether that's grade 0 or grade 1, that we're catching on CT, when we do corresponding TE images, we're not seeing them. And then when we do these high-grade areas of hypoattenuation thickening, we can actually correlate with CT. And because we're finding all these low-grade hypoattenuation thickenings that we're not seeing on TE that are concerning for thrombus, they're likely very not insignificant. There's something that we just do, no therapeutic measures are needed and no additional imaging is required. But if you have these high-grade, grade 2 or grade 3, it's recommended to initiate treatment for device-related thrombus, and you want to repeat that cardiac imaging in about 1 to 3 months to see if that has resolved. If it has resolved, you can de-escalate therapy and either consider repeating another imaging study or not doing imaging. If a patient still has persistent device-related thrombus after 1 to 3 months, it's considered to recommend changing oral anticoagulation. All right, and that's just my sources for my talk today.
Thank you, Dr. Adams.